welcome to our last luncheon seminar of this semester, and pretty soon we'll be talking about the fall semester, but not today. It is on. It is on. It's not on? Can you hear me? I can hear me. Can you hear me back there? More. Just, okay. Good. I'll just hang on here. I had the good fortune to meet Dr. Rwabukwisi about 2 years ago when he accompanied his wife, here now, to a meeting here at the university. They had just moved back to the States, where his wife, Jess, is from, and where he had received part of his education. The three of us had a lunch together, and Felix was interested in my work in Rwanda, and in particular my 2 Rwanda handbooks, which many of you have seen. He offered to arrange for them to be used in high schools in his native land, and I was elated. And we're working together on that now. It was only after that first meeting that I learned that he was a medical doctor, not just a spouse. Indeed, Felix is a doctor and a passionate proponent of public health. Soon thereafter, he joined the faculty of what was then the Commonwealth Medical College, now the Geisinger Commonwealth School of Medicine. Felix is not only a proponent of public health, but a leader in that field. His specialty, as he describes it, is to harness knowledge generation and utilization to ensure that research and academic work are leveraged with service delivery. His aim has always been to bring the best, well-researched findings to improve the lives of people in their communities, blending global knowledge with local concerns. It is with a noble approach to the medical profession. It is both idealistic and pragmatic. So here he comes. Please welcome Felix to the podium.
Thank you, Sandra.
I did fail to mention that his medical education was at the National University in Rwanda, and he has a Master of Public Health from Harvard University.
Thank you, Sandra. Yeah. Thank you, Sandra. And thank you all for coming today. So today I will really share stories of what we did in Africa, what I did in Latin America, some of the projects I've been involved with. But all of it will be based on a paper we just published in BMC Health Research Journal, which is a journal here in the United States that's known. It has different sections. It has lab, health service research, and pharmaceutical research. So, yeah, I forgot my clicker there, so I'll keep it. So this is the title, and it's also the title of the paper. But before I go in details, I would like to share more about myself. How I end up leading this paper with my colleagues from Ghana, Mozambique, Tanzania, Rwanda, and Zambia, and some other colleagues from the US as well, and also why this topic is close to my heart. And I was discussing with my wife when I prepared this. I said, I need to reflect back and see when is the first time I thought about health or life as really something necessary. And as we were discussing, we went back to when I was 13 years old. That's 1994, around this time in Rwanda. And at that time, in Rwanda, you might have learned about it. There was genocide happening. And to me, it was a debate of saying, why should I survive? Because I didn't want to say, I just want to survive, but I just want to say, why should I survive? And 2 things that I recalled was vividly, I was saying, this is really how I was praying, is to be able to heal the wounds that was around me, and I couldn't find a reason why should I be any different from those. People I believe they could save me, people I believe they are powerful to protect me, all were in that category of people who are wounded or are injured in different ways. The other way was to be able to convince people that killing was not necessary. So those are two things saying, God, if I have to survive, this is why. Otherwise, why am I different than all those who are going? So that was really how I feel at that time life was really necessary and I needed it. I needed it for a reason. The rest is, now we are 25 years, almost 25 years later. We are in April and I'm here, and yesterday we were celebrating my son's first birthday. Things are different. He's happy. So things have moved in the right direction, I would say. And apart that story, Sondra mentioned about my education. It was in Rwanda, Université Nationale de Rwanda. And you will notice that in 2009, right after graduation, because after graduation we went to serve in the community area, in rural areas. Many challenges, we'll talk about them later. And I had to come to the US. The first time I came to the US in Vermont, the School of International Training, I was learning about conflict transformation across cultures. That's how I met with my wife. And that's another interesting story. When I was trying to merge these two goals or mission at the same time. I was working with an organization that was focusing on social justice and health equity, and I wanted to understand how those two merge together in the real life. 2014, I graduated from the now teacher in Harvard School of Public Health. Used to be just Harvard School of Public Health. And I was trying to say, what we are doing, can we measure it? And that was really the reason I joined this master's program. I wanted to be able to learn about research strategies, research methodology, so that whatever we do in health and whatever I do in civic engagement, I can be able to measure it, evaluate it, and translate it so that others can use it. And I'm still working on that. I graduated from school, but I'm still working on learning how to do that. So my students will tell you. And today, what I will share with you, I try to summarize the last 8 years into 3 categories. First is HIV response. That's how I started working after graduating from medical school. I was working in Rwanda, try to scale the treatment as much as we could. And I was involved with projects elsewhere by proxy. My colleagues, I was in Haiti after the earthquake. My colleagues were working in other places of the world, and we'll discuss strategies on how we can learn from each other to make sure that HIV is controlled and taken care of. Second is the work on strengthening the health system in general. We will discuss what that means. Because what people needed in countries like that was not just HIV care. Issues were beyond that. And I will share with you what that means. And lastly is engaging with national level policy making in Rwanda and a couple other places. I worked as a consultant a little bit for the Rwandan government, working with CDC and others to review the HIV strategic plan, the last one that we're working on. That was my last assignment before I came here. So with that, I want then to go in the field, because I think that's what, I can share it more. And I mentioned 5 countries that the paper I just read narrate about. Those are like Ghana, Rwanda, Tanzania, Mozambique. That's how we will see geographically. And the reason I chose this paper is because I was tasked to summarize what we learned in implementing primary health care improvement intervention across these countries. So I was part of the consortium of many universities, you will see them later. We won a grant from the Doris Duke Charitable Foundation. It was for 5 years to improve primary health care in Africa. So we had teams in Ghana, we had teams in Tanzania, teams in Mozambique, and teams in Zambia. And my task was really to put together what everyone did and see if we can draw some conclusion that can be meaningful. And we'll talk about those today. More about the countries. This is geographic, if you look at the map, where the work was happening. More data about the countries. I don't know the background for everyone, but I wanted to share more information. This, if you want to understand what those countries means in terms of the size of the population, this is the column. Like Ghana had this is in millions of people, 29.5 million people. Rwanda is the smallest, but mostly the density is higher in Rwanda, even if it's just 12 million. Life expectancy, you can tell that there is some improvement and some hope. Most of the countries really improved, and this, I use the data that's generated by the WHO. So you can rely on it that way. GDP, share active productivity, and I use this other index because it doesn't tell only about how productive people are, but this tells about how the distribution is within each country. So it goes from 0 to 100. So 100 means pure equity, where everyone has similar wealth and they live the same way. And if you are 10% or low is where you have big variety in terms of wealth in the country. So you can tell countries are doing a little okay. You can tell that in Tanzania you will find pockets of very poor people and pockets with really wealth areas where life is different in those countries. And I just wanted to share that. And this index, Sondra is here. I had to talk about democratic index. This index tells how long those countries have had democratic institutions. So if countries like Rwanda, we had disruption of change in power, some of the authoritarian regime, it will bring the score down. So this score goes from -10 to 10. And I don't have a column saying how people are willing to exercise their civic engagement rights and duty. That one we'll have to research it. But at least this tells you what are those countries, where we were working, what we were doing. And I want to define something else, health system. This is where we were geographically, so that we understand where we were. This is the countries. And what do I mean by health system? Here in the US, if you talk about the health system, you will correct me if I'm wrong. The way I summarize it is very simple. We are thinking about the patient who are sick, the providers who treat them, and the patients who purchase coverage for those services, and then the insurance who are paying for those services. Did I get it right? That's how, if I talk about health system, that's what comes to my mind. And then what's used in the US, normally we say health system engineering. Can we engineer the system so that those transactions are fair and appropriate and correct? However, if you go in developing countries, each country does not really have their own definition of health system. We still rely on the WHO. Some of the reason is lack of resources or lack of the capacity to design or to have proper research to design those systems. So the WHO defines health system in 6 pillars, as they say. You need to have enough services, HIV, malaria, cancer, primary health care, that what people come to get at the clinic. You need to have enough health workforce in number and also in quality. Are they trained appropriately? Medical product, I have a pharmacy students here. We need to have access to medical consumables. I will use consumables, it's better. Because if I say, yeah, medical product, it's consumables and technologies, and you need to be able to use the information. And WHO also mentioned about governance. How are decisions made within that system? And again, the financing. Most of these countries, it's not the patient who purchases a coverage and then insurance which pays. In these countries, there is a national budget, which is supposed to be distributed across the country so that people can access the services. That's why we have within the countries levels, so that that money is managed sparingly. You will have, let's say you have a fever, you will start at the community level. People will assess you, and if you need admission, they will watch you under some primary basic treatment. If you are in their vicinity for 2 days, then they will refer you for more testing, so that the diagnostic can be made. And here you can have some minor surgery, some basic, and tertiary and central level depending on how your condition is complicated. And remember, in this system, services, health workforce, medical product, information system, and governance, the doors moves up as you move higher. So here you will have people who are trained minimally 2 years, 3 years of clinical training, and here you will have specialties as you have them here. So that you understand what I'm meaning when I discuss about health system. So I'm going to discuss how we've been trying to make sure that health system as defined by WHO was optimized across all these levels in those 5 countries. That's the story. So let's see then with real stories then, with real patients. This is I went back on my Facebook page. These days we use Facebook. We have to, to understand me. That's our archive, that's our library. I went to my Facebook page and I posted this picture on October 2009. At that time, it was my second year in practicing in Rwanda. And this is me. And these are kids. Some of them were part of my cohort. Some of them have HIV. And this is their teachers. And this is a mother and siblings coming with me. This is my car there, and my chauffeur was taking a picture. So what I'm trying to say here was from a night shift, from a second level healthcare facility, where we could do some basic, a little bit advanced than the community. And I had to follow my patients in the community. But I could not find any of them at the clinic. I had to go to find them at school. And this is the school. This is where they're sitting here. This is the school. And they had to cut. The mom came to me, said, like, I came without the child. I won't mention his name. We have to go where they are because they have to take the tests. You will understand. So we drove back. And what was challenging to me is not only him, because I had to follow him monthly. He was sick, but some of them had different issues. I could tell, I could screen, and that was one of the challenges. Like, I'm going to take one back to the clinic. I do the physical, I do the evaluation, I prescribe the medication. But what about these others at the clinic? That was one challenge there. I'm not even mentioning about how they are learning. Sometimes I will have to stop and discuss some math, basic math, discuss if they're preparing. That was not part of my job description, but it was a necessity on the ground. So, and then we can discuss, and then with my colleagues, we had to come up with an idea to carry some basic treatment with us. Treating fungal infection, mending wounds, some basic deworming, some basic things that normally anyone should have access to. But only, at that time, allow me to say it, only HIV people or infected patients, we used to call it HIV money. It was, they had funding, we had to respect the rules of the grant, and we have to treat them appropriately so that we can show outcome. They will tend to do better in this population than non-HIV population. That was challenging, and I'll explain why and how the grant was helping us. Another picture. This is a mother coming to my clinic. They managed to come. And she brings this one who's infected, and the rest are healthy. They're coming to my clinic. What else do you see in this picture? What can you notice in this picture? Pardon? Yeah, I just did it for the picture, yeah. They allowed me to post this picture back in this time, but I just covered, yeah. What else would you notice?
Well, she was prosperous, like middle class or
Yeah, she had no clothes, she has a purse, handbag, yeah, they have shoes. This was an issue. Yeah. What else? These are twins. These are twins, and this is the sibling. She was 6, 7, something like that. What else? There's a gate. We had a big debate. Should we have a gate at our hospital in these settings? Because somehow the gate was ready to keep people outside, and we wanted everyone to come in. This is at the time where people could die from home, and we wanted everyone to come in. We didn't care about the costs. Just let them come. We'll figure out the costs later. I was in charge of the budget. We could find reallocations, and at least we can treat people. And what I wanted to share with you, you might say there is child labor here. I did not tell you how long did they work for to come to the clinic. I did not talk about, did they eat in the morning? Who prepared the food? Who washed them? And how much energy this child is producing, carrying her siblings to the clinic? Did she miss school? Yes or no? Many issues that were, and the only one who is coming to receive health care was the HIV infected one. So if these were not covered by health insurance, they will not receive care at that time. So I will sit in the clinic and I will have to make a decision. What do I do? Sometimes he will be doing well, she will have an ear infection. Should I give an antibiotics, yes or no? Would I justify that in the budget? That's another question. Because I had to juggle all those tensions. So this is the situation we had. And this is why, discussing with some of the officials from Doris Duke Foundation, they understood the challenge at that time. They said, then what would you do? We didn't have any solution. You will look into papers, you will look who published about it. How would you make sure that with a minimum budget, you can make sure that all the services needed by all these people, even the mother, I do not talk about the mother. She might have her own issues and problems, yeah. That might be costly, and she might pretend to do well because she wants her kids to be treated. That's another story, I will not go into that. And we're discussing and say, how should we do? The way we designed the grant, we said, like, okay, we have a good framework. The reason we use the framework is these issues are complicated. There is no one solution. You have to really have a framework to follow so that you make sure your answers are balanced. And this is busy. I will make it easy. But this was the summary I put in the paper. So you can tell like who won that grant. You can tell like Columbia University, some of the faculty joiners, University of Washington, Brigham and Women's Hospital, the Harvard Medical School, and this here, I think this was London School. I don't remember. Yeah, and this is all the intervention and how teams in these different countries prioritize different area depending on what health issues they were dealing with. And I will just share with you the population size who benefited from the intervention and what they choose from the WHO framework. Because some will say, no, we think we have enough services. And then we choose to train physicians or nurses. Others will say, no, we think we have relatively a good number of trained physicians. We will choose to information and technology so that decisions are made appropriately using data, using information, which was also necessary. Others will say, no, we will choose drug supply chain. People in rural areas don't have enough drugs. So it was differently, but we needed to evaluate population outcome the same way. That was also a statistical challenge. So in Ghana, in this initiative, 500 people in the area Upper East Ghana, and for them, they chose to scale at secondary level the intervention they had proved to work. It was a community health program to improve new and child-born health. So they had done it on a small scale, it was functioning, and they wanted to know if they can scale it. They were saying, like, if we can really make sure that we improve child mortality and newborn mortality, we think we'll do a good job in general. And one of the biggest components was actually transportation. How to make sure that mothers who need urgent care or who are in labor reach health facility in time. As simple as that. Because depending on how the roads are and where they're coming from. In Mozambique, for them, they chose data utilization for decision making. So they say we have relatively good enough clinicians, we have facilities, we have drug supply chain is okay, but we are challenged on how decisions are made. Are people using data? Are they tracking progress? How are they doing it? And this was really very simple as telling people how to collect data. People designed data collection sheet and show people how to collect it, how to report it, and how to use it to make decisions. As simple as that. That was the intervention. And it wasn't easy as I speak about it. It took 5 years to make sure that is really reliably done over time. In Rwanda, the challenge was post-genocide. The government wants everyone to have care. Healthcare equity was big at that time in the discussion. And we wanted to have a system-wide approach, which was challenging. But I would say that some of you can tell clinical mentorship involved all types of services that were available at each level. So what we did is really to train coaches who will go facility to facility with checklists and work with clinicians on the field and watch them and give them feedback so that they can improve how they're treating patients. Amazing program. It's being now scaled in many countries, in Liberia and Haiti, yeah. And this was really working with nurses and see how we can use coaching strategies so that, in general, if you leave, care would be optimum and safe. And then the other challenge we had was neonatal mortality. Child mortality was going down, under 5, but if you look at under 5 going down, you might say, oh, we are doing a great job. But neonatal mortality was flat. It wasn't moving. So we had to come up with a special intervention for that period of life. And then research capacity building. So that as we are doing this, can we train people on how to evaluate and disseminate these findings? Those are like what I could share. And you can tell 500 people benefited from it. Tanzania, that was an interesting program that I still think is valuable. The Community Health Urgent program was a career path to health professional. They were really dealing with professional, here we'll use the term professional identity, how they form. They were saying, before you go to a health profession, can you serve a term as a community health agent? So that you'll have a process, you graduate from high school, before you go to college in a health profession, you serve 2 years as a community health agent. Then you get to know the patient, you get to know how the system functions, you get to develop the purpose around that area, and then you can get a scholarship to go either nursing, pharmacy, medical school. As a concept, it was a good concept and was functioning. They had many challenges in the design, but yeah, that the idea was good that way. And then in Zambia, it was a real research facility. They just focused on testing their clinical research, their clinical protocols they have at the community level. Because at the community level, checklists and protocols tend to provide better care. If someone knows, like, if I get a patient, I go through these points, A, B, C, D, then I make this decision. And they were trying to evaluate if that would work. So that's the summary of the intervention. That's what I wrote about. And there are many papers. There are many papers around all these interventions, how they evolved over time, what they did. And the summary of the reasons, and I will do it in a way that I will say the reason we learned and what might mean in the US. And help me if my comparison and parallel is correct. Lesson one, very simple. It's known. If we work together, things will happen. Yeah, we needed to involve everyone. Like, we could not design good intervention at this time without talking to patients, without talking to community health workers, without talking to leaders telling us, like, look, if you bring a new ambulance, the driver you give it to might just decide to take his child to school first. They need to go to school, they don't need to work. And you don't have a system to monitor that. You don't have a GPS, he might do that. And we need to discuss with local leaders and people to find out how will we do this. And then, of course, we discuss with national level leaders. At that time, I will go from that clinic with kids, and in the afternoon, I will be in the Ministry of Health discussing the new grant, the new challenge. So I had to use different part of my brain or switch each time during the day. And my colleagues as well, it's not only me. And I was thinking about it and said, like, what would this partnership mean in US? Some of my students are here. There are many things I can talk about or can research about, but I was thinking that what is the patient? How do we involve the patient in this? Do we have a real true partnership with the patient in the US? And I might ask you, how do you feel engaged as a patient in the health system and how, in the care you get? That's what I could come up as a question, but you might have different experience and more knowledge about this. But this is for us. Reviewing the health system required discussing with everyone who is involved and really have a way to incorporate their feedback and what they have to say in the system, regardless the design. Some of the grants were failing. Good NIH grants, but you look at over time, outcomes are not moving. This was necessary. Lesson one. 2, learning culture. I shared with you how you will go in the clinic and will find there is a shortage in the drug supply. You started with a good design, you have a good statistical design to say, I'm going to review how clinical protocols are used. Or I'm going to train community health workers. You have good trainings, handbooks are printed, trainers training are done, you have people coming. After you train them, they go to apply what they learn. There is no medication. What is the purpose of that work? At the end, you won't really achieve anything. So we needed to be able to change the design as we go so that we can accommodate those challenges in the context. And we were lucky that the grant allowed it, and our challenge was to be able to evaluate it. Because most of the time when there's a lot of variation, you end up seeing no improvement. That was a challenge both on the field and on the statistician who was helping us doing this. What is a learning culture in the US could mean? I don't know. And I will go to my favorite, sometimes topic I've been involved with so far. Do we have ways to use patient safety or patient safety failures to learn and to improve? That's what I teach at the school. We teach quality improvement, patient safety, and I see many ways that can be done. And there are many other ways. How do we use research? And I'm saying this because in developing world, people refer to the US. Because that's where academics are, that's where most research are produced, and that's where people come to learn. So I'm just saying that way. That's really the reference. And many of the countries follow WHO. Lesson 3. This might sound a little bit complicated, but simply it's how do we get things done? Simple. If you say I'm going to teach a class, how do you get people there? And how do you manage time? And how do you teach them the right content? As simple as that. And we had to use checklists. We had to use some of the, I don't know if you're familiar with the PDSA cycles, things that will help you see if the work is being done the way it's supposed to be done. And I was discussing with some of the pharmacists, like, here I've been introduced the interprofessionalism and teamwork. That's how you will see, in the way we heard about health system in the US, that way I could say, oh, getting things done means to engineer things so that teamwork and people understand how research can be translated into action at this level. Yeah. Last lesson, sustainability. Those problems were really complex problems, and we needed at least enough time to generate data, enough data to make some conclusion, enough time to make sure those change process we introduce will take effect, and people abide to them and get used to them and function. And at the end, in Rwanda, we're discussing, now the grant is over, what could be sustainable? Do we need more money? How much money? Do we need more programs? How many programs? HIV, cancer, diabetics, everything. It was challenging. One way we needed to do something new, and one way was to invest in education. Yeah. Education could be one way to sustain those gains we had. If we know something works, how do we make sure it's done everywhere, even if we are not supervising it? One way was education in general. And here, the discussion is varied. I'm not an expert yet on the context, but I've seen, like, should we have personalized care? Is it possible to involve the patient? I keep talking about the patient from the beginning. Patient engagement, patient safety, is there possible to design system involving the patient? Can it be sustainable that way, as an idea? Whatever you do, if you have the beneficiary involved, is it sustainable that way, or is it not sustainable if you design it the other way? And to summarize, I will go back to my framework to see like health system and health system engineering, if I would use that way. Here, the WHO was setting these standards. This is, we think, if you have a nurse, a pharmacist, and a generalist at the secondary level, you'll have better care. Then everyone is trying to reach that. And in the countries, they're saying, we need to make sure that at each level, everyone who reaches that level will have everything they need, and that's produced at that level. And I was discussing in my topic, I said, like, why global health is a local issue or global issue. And I was saying, what role my colleagues who are in Rwanda now would see me, who they say, like, now you're an American, what role do I have to play now for global health? Do I have a role? Or the US, with enough knowledge, with enough resources, is there a role to play to make sure this functions? That's what questions I don't know have the answer, but that's how I feel like the health is an issue really everywhere. And this is how it ends. This is like maybe 4,000 years ago. So questions?
In the development of this broader health setup that you're doing in Africa, are your patients kind of seeing the parallels to seeing a nurse practitioner now? I mean, years ago, we all went to the doctor and we saw a doctor. And now we don't always see a doctor, sorry, unless we're sick. So is that how your system will evolve? So these like level, 2-year level trained medical people in that primary level or the lowest level clinic. And do you see the parallel to medicine here?
That's an interesting question. Yeah. I would say, first of all, if I didn't have nurses, I wouldn't have achieved anything that time. Because they were there, I was the only one, maybe have 30 patients in my ward, in pediatric ward, and I will have 2 sick children by bed. What would I do? And nurses were close to the patients, were monitoring everything we did, and they had really a more humane connection with the patient. I needed them as I was figuring out what to do with that big word. And I would say, I don't know if this should be going to nurse leading that process. I think what is needed is to that humane connection with the patient. Because every patient is unique. And we need to find ways to have that connection and maintain it. Whether it's by nurses, another label of whoever will do that work, that's what I would say. I see things lead to. They have to, otherwise it will not be sustainable. Yeah. Listen, you help me go with this one.
Bringing it close to home, what is your goal in being here at the Geisinger Commonwealth Medical School? And how do you go about your work here? Interesting question again.
I have a wish so far. I don't think I would say I have a specific goal. I'm still learning. I'm surrounded with people who are really guiding me. As shifting from global health system to the United States, first of all, I can't practice yet. I will need to probably work on that. But I would say the issues I shared, so far I teach patient safety, quality improvement, community health research. I see a value in that. And I see a value in that because they are connected to real people, to patients, and to where people are. And we can do a lot that way. And the school has tremendous opportunities and potential. That's what I see, and that's what I see myself being involved with. Yeah, going forward. I don't know if I answered, yeah.
Approximately 5 years ago, our son worked for a year in Tanzania with the Clinton Health Initiative. And his task was to go out to the villages and teach the women who the women were HIV positive, but their babies were not HIV positive, to give them formula and to not breastfeed. They provided the formula, and he came home very frustrated. He felt that he made no difference whatsoever. The women continued to nurse the babies, and the babies continued then to be diagnosed with HIV. And he was very frustrated because they tried many different ways of addressing the culture.
Yeah, many layers of discussion. So I laid a program like that. I published on it. We called it HIV-Free Survival Program. We used formula. It worked very well. we had 0 maternal to child transmission. It was very efficient. One of the challenge was the cost. Second is mothers need to breastfeed sometimes. Sometimes they need it and you won't stop it because that's the only connection and that's the only food they would see. Because they were telling us, how long will you be here for? I don't know if I'll be able to afford formula, let alone using formula appropriately. Do they have a way to clean bottles? If they don't even have water to cook, do they have enough resources to boil the water? Those are our questions. And yeah, go ahead, we're say.
Understanding was that they would continue to provide the formula, but the woman would be shamed. And it would be known then in the village that she was HIV positive, and she did not want us to know.
Yeah, that I was going.
That's the reason they did not use the formula.
Yeah, and I was going to go to that. That talks about the stigma. I was fortunate. The area we worked in, community health workers and the population helped us a lot to make sure the stigma was not there. People were not afraid to come to the clinic. And that means the challenge was in the culture, the challenge was how are they involving the community? Because if you're facing stigma, there is no rule, there's no cure to stigma, there's no pill you will give for people to not be stigmatized. You need to talk with people, you need to discuss with people and see why are they stigmatizing others. And in that process, you can come up with better situations and less stigma. And that's why I went to learn about civic engagement. I needed to understand, if I want to do something not medical intervention, how would I do it? Yeah. And I wanted to say something else. Now with what is happening now, mothers can breastfeed with treatment. If you bring the HIV in their blood, you suppress it, they can breastfeed safely. That was the last program I worked on before I left. At least that issue was somehow resolved, but the stigma is there and you have to address it. Yeah, and the only way to address it is to engage people and work with them. That's how I would say it. Yeah, I don't know if there's a question here. Yeah.
Do you see a complementary role for traditional medicine in the systems you're creating?
We needed them. And the only way we needed them, we engaged them as community health workers. As simple as that. Because they had one big thing. They had big trust from the patients. Because they were the doctors in the community. And I could not come from the capital and go in the room and say, oh, now I'm the person. Who are you? You are young. It's probably we don't connect. We don't hang out where we are in the evening or when we go to the field, we don't know where you are not there. We needed to work with them as community health workers. And some of them accepted it. And some of them started referring patients to us. Some of them will say, okay, look, you come to me as a traditional healer, but these issues with wounds, those guys will do it better. But as we can discuss more about the stigma, about the counseling, and the other, and I would say I don't know how good was our work to control the safety issue regarding anything they might have in the traditional healing, because they are fake traditional healers too. They are fake traditional healers who will not tell the truth to the patients. If they cannot do something, they will not say it. Though that's a challenge. Yeah, but I think we try to engage them, and that's how we went around it. Yeah. I don't know if my answer is so. Yeah.
Okay. Thank you. First of all, I'm really glad that you've brought this on table.
Mm-hmm.
Health is a very big problem, and as you've mentioned, the U.S. is a different world.
Mm-hmm.
The realities we found here on the ground, they're really different from what we've realized back in Africa.
Mm-hmm.
And my question is, all that you've been doing, I think, has been because you had grants.
Mm-hmm.
And I don't think anything can happen in Africa without money. This is a fact, we all have to agree. Now, the question is, from all what you've been doing, and you ran short of grants and some programs failing to be implemented, what do you think is the long-lasting solution to health problems in Africa as a health expert?
further to that, for us, we reached a level where we felt like we've improved primary health care. I had children in my cohort who became or gotten better care over time. We started to introduce like a cancer program in the Rwanda that was unique, and I was proud to see that happening. That was through collaboration with Dana-Farber. And they were saying like, is this the best way to keep doing it? Do we add the program, then how much money will we need? Then the issue goes beyond health. The issue goes beyond health because then you will need to discuss how is grant making, what are the rules, how is it managed, and what the outcome, and then you need to involve other people. Yeah, and I did not mention it, I was saying that normally, traditionally in the US, global health engagement or the grants are mainly for security, marketing, or charity, like those were the only reason. But the way they are designed that way, there might be some limitation. There might be another reason to do global health through collaboration. I've seen working with residents or attendants from the Brigham and women in Rwanda was different. Having one person there could introduce different type of care. There are conditions I could not diagnose if I didn't work with them. And having them there was a big cost. How do we negotiate their FTEs from the institution here to go in Rwanda? Because for their colleague here, it's a challenge. Where are you going? We need you. We are busy. And you have to address that appropriately. So to answer your question, it's work in progress. We need time. We need engagement. And I think education will do a big role, will play a big role in that. Yeah, that's how I would say it.
Okay.
Oh.
Okay. We, in America, in our country, we have some terrible blots on our history under the guise of public health. And I guess I'm wondering a couple of things. You have any evidence of experimentation going on in any of the countries that you speak of under the guise of public health? And to push that further, where do you stand with, because it's very controversial here, stem cell research, that kind of thing, as you as doctors that we do, the organs that are being grown and that sort of thing. Would you respond to those things?
The philosophical and ethical. What I will share with you.
Well, I think there will always be a black mark.
Yeah. Yeah. I will share with starting from the Africa and the experiment. Yes, the experiment. Do we need them? That's one way knowledge is created so far. That's the one way we know how to do to create knowledge, and this through research. And I would say the only comment we had back in time, at least in Rwanda, I managed to do, there used to be drug development research in Africa, and after the drug is approved, people will not have access to it. What happened in Rwanda, I can share openly, is the HPV vaccine. That's where the country managed to vaccine everyone. But the argument is like, even if you do the experiment, those populations should not really have to buy. If you develop a drug in Gabon, and then it takes 100 years or 50 years later for someone in Gabon to receive that treatment that was developed there, I don't see that quite right. There could be some creative way to go around it. And on the stem cells, I think there's a debate. It needs to be a debate. That knowledge is needed. There is a value. And for a single patient who might benefit from it, they will tell you this is really needed. But in general, and the approach and people to be wise to do it appropriately and safely, yeah, I think it's a little bit, I'm not involved with it yet to know all the issues that has been there. I cannot list them now, but that's the best answer I can provide. Yeah. It needs people to talk, needs people to discuss, and to provide the best answer they can come up with, and the best approach. Yeah.
Ready?
Oh my God, it's so weird. To piggyback on the question about grants and funding. So you talk about how your organization, you have to follow the conditions of the grants. So like with the key state players and stuff like that. What is your opinion on organizations like NGOs like Médecins Sans Frontières, who like get grants and funding from like individual sources and private sources in order to like remove any bias from like this, or like any influence from like the state players, or you know they don't receive funding from like big tobacco or any pharmaceutical company. What's your opinion on that?
Yeah, that's a big question too. So I worked with an organization that were mostly funded by private donors. We did not receive like US government donor, but we used people, generous people's money. The good thing about that, you can be flexible and creative. They can accept some of the model and approaches we were following that are not guided by the government, and that helped. And in terms of rules, there's still rules, because then if you work with the government, they have control in their area. You have to discuss with them. Yeah, you have to discuss them. I think like through discussion and openness to creativity, there are many things that can be possible. And to the MSF, Médecins Sans Frontières. Médecins Sans Frontières, they're doing an amazing job. We used to criticize because we are saying like, amazing job and then they leave, but if you save lives in an emergency situation, it's still a noble cause and achievement. So I think they're doing a good job so far. That's what I can say. But again, to his question, time is needed and engaging people is still needed. You can't feel like tomorrow will be done. We get 10 years grant and everything will be fixed. No, that will be, it's not, yeah. I don't know if I answered your question. Yeah. Uh-oh.
So I know I have a lifetime to ask this question, but I just thought, why not pose it so everybody can hear your response? When you came to the United States, what was, and you know, being a physician and someone who's really worked at all of the different levels in Rwanda, from the ministerial level down to the community level, when you came to the United States, what was your biggest surprise? Now that you have, you know, health insurance in the United States, you've had to access U.S. healthcare. What was your biggest surprise? Like, oh my gosh, I can't believe that this is the reality on the ground here. Thanks. Sorry.
She knows the answer, but I don't know. There are things I don't want. I'm not yet ready to talk about because I don't fully understand them. But what I will say, there is possibilities in this country. I can see, even going, I used to do simple math, driving around, counting how many health facilities I see on the road and how big the population is. Just health facility population level. I was like, oh, there's a lot that's possible here. If you gave it to me, there's be no one person sick. Because I said like, oh. And then in Rwanda, you have one CT scan. We used to work with one CT scan for 10 million people. Prioritizing that was challenging. We will have sort of team aboard to say like, okay, I have 30 patients from different clinicians who are working. I have a small budget. Who do I decide to send to Uganda for radiology, for example? How do I pick one person who needs radiology and the other one, a kid who needs a transplant? Who needs a kidney transplant? How do I make that decision? And how do I make sure at least these children I have in my chronic care clinic get diagnosis? Some of them we didn't know what they're suffering from. We will just keep them in a sort of palliative care process. Just follow them, examining them, making sure there is no sudden infection that will make them worse. But we're still looking for how to diagnose them. And now those are not issues here. If you go to any clinic, you will get care. If you can afford it, you will really get care here. And that's really something I say, yeah, there is possibilities, there is knowledge, and there is resources. That's big. Yeah.
Let me ask the reciprocal of that. What programs in any of the 5 countries that you've discussed that you find not available here that you would like to see incorporated into our healthcare system?
Community health worker. Community health workers, in the US it's there, but not as the way I saw it. I used to say, like, even all the community health agents in Tanzania, I used to discuss with some of my colleagues saying, why can't we have medical students do some navigation? It's possible in the areas. I don't know how much time we that need, but that connection with the patient will create change. Anyone here have been sick at some point? Yeah, as patients, how were we taken care of? And who did we work with? Did we ever think, like, I wish I could have someone to share XYZ? The best person you go to is your spouse or your best friend, and some of the information you share with them could be beneficial to your care. It happened to me, and I don't know if anyone else have had that. What we had, community health workers were really close friends to their patients, and they told us everything we needed to know. What are the challenges the patient has to take their medication? Within 20 minutes or 30 minutes you have a patient in your clinic, there are things you will not reach. You will talk about major issues, and time will go by, then you will refer to a social worker to do the rest. That's something I see, and also you mentioned about it, like how we're going forward. Those information that are shared in intimacy, I don't know how they are leveraged in this country, in the clinic. Yeah. I'm still learning. I will learn, as I spend more time.
Do you think there's a role for the medical schools, the physicians in this country to go to Africa and teach and participate in some of the education? Do you think, as a professor here at the medical school, do you think that that's something that would be worthwhile?
I wish can be done more. Yeah, we had a grant in Rwanda. We had a grant in Rwanda with some universities came, they called HRH, Human Resource for Health. Universities came to train residency, and ideas we had in the beginning were big. But the challenges after we started the program will not help us really reach where we needed to go. First of all, there is the budget and the time, because going to teach, you need consistency. You need to really be there enough time to understand where people are, and to, as you're teaching, to stay with people until the completion of whatever you are teaching them. And that consistency, we did not achieve it. And later on, to afford their time here.
Do you think that an organization like Health Volunteers Overseas would meet some of those consistencies?
Yeah, if you have an engagement for medical school and the hospital, you could achieve that. Because then you will negotiate that time. Because that was the challenge. If physicians here need their time here. Because they are part of a team, they have workloads, and they have to respond to their employer. Do we need to find a way to discuss the management of that time? But the role is there. One graduate of from a medical school from US can teach many people there. Even in Rwanda, we had one physician for 20,000 people. Anything you can give to them, anything, any communication, even time to process some issues, it will be beneficial. That's the ratio. Yeah, and here the ratio is very different. I don't know if yeah.
We have a very big middle class in this country. You have some middle class people in Rwanda and other places. How do they fare in terms of medical care?
Yeah, so it's hard to compare middle class and middle class in Rwanda, but I would say like what I've seen here in middle class, the level of education is high, and the capacity to be engaged in healthcare is a little higher. Yeah, and in Rwanda, or not in Rwanda, in developing countries, sometimes you don't even have that middle class. You have people who are leading a life like you, people live here in the US, and you have people who are leading a life that's really back in history, who don't have access to shoes, who don't have access to 2 meals a day. There is a big range. And to them, talking about engagement, telling them that go exercise. This is the right food to eat. This is the plate. Protein, vegetables. They don't even have the bad food. That's really different. So that's how different. And here it's really, there is potential and you can do it here to engage them in the healthcare system. Yeah, I don't know if I said it right.
There more questions? Well, let us thank her. I hope that you feel as I do that we had a great opportunity today to learn about how different it is in some places that we take for granted. You know, if the doctor makes you wait a half hour, you're mad. You know, if you can't get an appointment on just the day you want, you don't like that. Well, this was a very telling talk, and we appreciate it, Felix, very much. Thank you. So this is the end of this is our 6th luncheon seminar this semester, so hold on for the fall. But we still have the bus trip for those who are lucky enough to have been able to sign up, and